Diagnosis and Management of Acute Lower Gastrointestinal Bleeding, European Society of Gastrointestinal Endoscopy, ESGE Guideline. Introduction. This ESGE Guideline aims to summarize the available evidence and provide guidance regarding the diagnosis and management of acute lower gastrointestinal bleeding, LGIB, focusing on the risk stratification of patients, the role of endoscopy and other modalities, interventional radiology, surgery, and on the appropriate management of antithrombotic agents in patients presenting with acute LGIB. All recommendations in this guideline apply to patients with major LGIB. Main recommendations. ESGE recommends that the initial assessment of patients presenting with acute lower gastrointestinal bleeding should include a history of comorbidities and medications that promote bleeding, hemodynamic parameters, physical examination, including digital rectal examination, and laboratory markers. A risk score can be used to aid but should not replace clinician judgment. Strong recommendation, low-quality evidence. ESGE recommends that, in patients presenting with a self-limited bleed and no adverse clinical features, an Oakland score of less than or equal to 8 points can be used to guide the clinician decision to discharge the patient for outpatient investigation. Strong recommendation, moderate quality evidence. ESGE recommends, in hemodynamically stable patients with acute lower gastrointestinal bleeding and no history of cardiovascular disease, a restrictive red blood cell transfusion strategy with a hemoglobin threshold of less than or equal to 7 deciliters, prompting red blood cell transfusion. A post-transfusion target hemoglobin concentration of 7 to 9 grams per deciliter is desirable. Strong recommendation, low-quality evidence. ESGE recommends, in hemodynamically stable patients with acute lower gastrointestinal bleeding and a history of acute or chronic cardiovascular disease, a more liberal red blood cell transfusion strategy with a hemoglobin threshold of less than or equal to 8 grams per deciliter, prompting red blood cell transfusion. A post-transfusion target hemoglobin concentration of greater than or equal to 10 grams per deciliter is desirable. Strong recommendation, low-quality evidence. ESGE recommends that, in patients with major acute lower gastrointestinal bleeding, colonoscopy should be performed sometime during their hospital stay because there is no high-quality evidence that early colonoscopy influences patient outcomes. Strong recommendation, low-quality evidence. ESGE recommends that patients with hemodynamic instability and suspected ongoing bleeding undergo computed tomography angiography before endoscopic or radiologic treatment to locate the site of bleeding. Strong recommendation, low-quality evidence. ESGE recommends withholding vitamin K antagonists in patients with major lower gastrointestinal bleeding and correcting their coagulopathy according to the severity of bleeding and their thrombotic risk. In patients with hemodynamic instability, we recommend administering intravenous vitamin K and 4-factor prothrombin complex concentrate, PCC, or fresh frozen plasma if PCC is not available. Strong recommendation, low-quality evidence. ESGE recommends temporarily withholding direct oral anticoagulants at presentation in patients with major lower gastrointestinal bleeding. Strong recommendation, low-quality evidence. ESGE does not recommend withholding aspirin in patients taking low-dose aspirin for secondary cardiovascular prevention. If withheld, low-dose aspirin should be resumed, preferably within 5 days or even earlier if hemostasis is achieved or there is no further evidence of bleeding. Strong recommendation, moderate quality evidence. ESGE does not recommend routinely discontinuing dual antiplatelet therapy, low-dose aspirin and P2Y12 receptor antagonist, before cardiology consultation. Continuation of the aspirin is recommended, whereas the P2Y12 receptor antagonist can be continued or temporarily interrupted according to the severity of bleeding and the ischemic risk. If interrupted, the P2Y12 receptor antagonist should be restarted within 5 days if still indicated. Strong recommendation, low-quality evidence.